So there could be one of the fallacies you can see, because the CT scan, MRI, whatever we are doing, are not going to give you the details of the the membranous labyrinth at the cellular level. So this is important. This cochlear, see the base of the, this is cochlear aperture. You can measure with your software the size of the aperture. This should, if it is too big, then can lead to gusher. If it is too narrow, this looks like around 2 mm. If it is too narrow, less than 1.4, it is assumed that could be cochlear nerve hypoplasia or deficiency. There are many other ways to look at that, and the decision making is altogether different. That's a different field. I am not going in detail, but this is one of the way we must look at the CT scan to rule out all those possibilities of cochlear nerve hypoplasia or deficiency. So CT scan has to be seen differently from cochlear implant. Now the another important thing, that the basal turn of the cochlea and immediate anterior structure to the basal turn. See here, what is this? That's the cochlea, that's the carotid artery. See, look at this, that the basal turn of the cochlea and immediately anterior to it is the carotid artery. That's the horizontal carotid artery. That is the vertical genu of the carotid artery, which is in millimetric distance from the cochlea. Sometimes this bone is deficient, and the literature supports, you will find from literature, some of the people have accidentally implanted the cochlear implant going from here directly into the carotid canal. Can be a disaster if you are unaware of it, or if it happens to damage, or while removing it, pulling it back and tear the carotid artery. All those are different aspects. We need to be very careful. So this cochlear carotid partition we must look at before every cochlear implant to see if any disaster which can happen. Another important thing, at the level of the round window. See, this is the level of this is the round window. This is the round window. That is the round window niche. See this, how thick the round window niche is we are going to get in this particular patient. We must be prepared to deal with a thick round window niche. Can you see here the thick round window niche? So these are important information we must know during CT scan. And at the level of the round window, if I go below, if I go below, now you see the jugular bulb. Sometimes the jugular bulb is too high, that too uncovered by the bone. See now, we have gone below the cochlea, no cochlea is seen, and now the jugular bulb is coming into the picture. As I go up, see now, as we see the cochlea, the jugular bulb has gone far off with a thick bone between this. So there is no risk of the jugular bulb injury or anything, or any challenge from the jugular bulb side to the cochlear implant surgeon. Another important thing we must see in coronal sections, there are few things we must look at the coronal section regarding the facial recess, regarding the favorable facial recess or the favorable round window. First is, look at the vertical segment of the facial nerve. This is vertical segment of the facial nerve. See, this is lateral canal. This is the lateral end of the canal here, lateral end of the canal here, and see the vertical segment of the facial nerve. So this vertical segment of the facial nerve is medial to the level of the canal. See that the lateral end of the lateral canal here, it is medial to it. Sometimes the facial nerve is too lateral to obscure the visualization of the round window. We must be very careful. And this was the classification initially proposed by Telmesani to see the difficulty in visualization of the round window. Second is this round window. That is the round window, the distance of the facial nerve to the round window. Again, see this. This is the facial nerve. Follow me. This is the facial nerve. This is the facial nerve. Here is the facial nerve where my cursor is, and see the distance from the round window. What is unfavorable round window? When the round window becomes too medial, when the round window, the facial nerve and the round window distance is less, the round window is posterior-medially directed close to the facial nerve, then the likelihood of the favorable round window is less. You can imagine, you can measure in terms of distance between the round window and facial nerve, whether it is a favorable or not favorable, unfavorable round window. So all these are important. See, for looking at the CT scan to give the optimum results of the cochlear implant, one must sit with the CT scan at least for half an hour to get the exact submillimetric three-dimensional information, which can complicate your cochlear implant surgery, which can have a significant impact on the overall implantation, surgical aspect, difficulties, or changing the surgical technique of the implantation. Next is the MRI, and I will quickly, our case is ready, and quickly come to the MRI. The sequence we look at the MRI almost always is the 3D CIS or the Fiesta sequence, or the heavily T2 weighted, imaging, wherein you can see the fluid of the inner ear as a bright sequence. In heavily T2 weighted, see the CSF signal bright. Similarly, the fluid in the cochlea is bright. As I said in the beginning, for a cochlear implant candidate, one must have a fluid-filled cochlea. Look at the cochlea, completely bright, fluid-filled with the interscalar partition very, very closely visible between the middle and the apical and the middle and the basal turn. You can see the interscalar participation with the scala tympani and the scala vestibuli, two different segments. The lower one is the scala tympani, the upper one in the vestibuli. Very, very clear on CT scan. That is the vestibular system, the vestibule and the lateral canal. That is endolymphatic sac and the duct. This is endolymphatic sac and duct. The lateral semicircular canal, vestibule, the basal turn, middle turn, and the apical turn, all full of fluid. This is the prerequisite for a cochlear implant to go. In situation like ossification, in situation like post-meningitis, post-traumatic, post-autosclerotic, there are many ways, many etiologies which can contribute to the, obliteration of the cochlea. And in complete obliteration, we know rules out the possibility of a successful implantation, though the surgical technique has advanced now with the advancement in the technique of the, the electrodes, wherein we can implant even the very, very difficult ossified cochlea to certain extent, not optimum, but to certain extent. Otherwise, the ABI is the final answer. And we all know why this is important to know. Even the worst result of the CI is the better than the best result of the ABI. Even if we could push some electrode to stimulate, certain aspect of the hair cells in the cochlea, we can get better hearing and speech recognition, better than the best results of the ABI. Now, how to look at the various nerve? What we need to see from the MRI is an intact cochlear nerve. How to look at it? First of all, dynamically, you can see where the cochlear nerve. This is cochlea, this is modulus, and see from the modulus dynamically, this nerve is emerging. This nerve is emerging and going to the cochlea. This is cochlear nerve. This nerve behind is the vestibular nerve. That is vestibular nerve. See this behind, the fullness behind the vestibular nerve. This space behind the vestibular nerve is the Scarpa's ganglion. The vestibular nerve ganglion behind. You can see very clear. So this is vestibular nerve, very clear. And this is the cochlear nerve. And in order to see the dimension of the cochlear nerve, the best sequence is the sagittal one. How to reach the sagittal section? On the MRI, 3D, go to the sagittal, and in the sagittal view, see this is sagittal view. Now I will tell you how to look at dynamically. It's not the static image which is important. Oh, sorry. It is the dynamic image which is important to know whether the cochlear nerve is adequate in diameter. This is important to know because a hypoplastic cochlear nerve can have a significant negative impact on the overall outcome of the cochlear implant surgery. So here, this is our sagittal view. See this sagittal view I have seen here. Let me show you which is the cochlear nerve, which is the, see in sagittal view, you will see four nerves. Four nerves, the picture is not very great, but here you see that is the cochlea laterally. From here, the cochlear nerve is emerging. In sagittal plane, let me take a better picture of the sagittal view. Yes. Yes, this is a much better picture of the sagittal. Can you see the four dots? Four dots of the four nerves. This is the orientation of nerves in the intra-auditory meatus. Now, which is cochlear nerve, which is vestibular nerve? See this. See, this is cochlea, and this inferior nerve is the cochlear nerve. This inferior nerve is the cochlear nerve. This is anterior-inferior. The anterior-superior is the facial nerve. Posterior-superior is the superior vestibular, and posterior-inferior is inferior vestibular. By and large, how can you make out this is facial nerve? This is cochlear nerve. The dimension of the cochlear nerve is generally bigger than all these nerves, generally by and large. A hypoplastic cochlear nerve is defined if the dimension of this cochlear nerve is less than the dimension of the facial nerve, by and large. Many times you may not find the cochlear nerve separately, yet, yet you can implant with guarded prognosis and you can find the hearing as the cochlear nerve fibers may be traversing through other nerve. But by and large, if this, see in this particular case, the cochlear nerve dimension is normal. If it is hypoplastic, then you have to take the help of other electric tests. You need to counsel the patient more and more to give a guarded prognosis that in case the cochlear nerve is not functioning, dehiscent, absent, hypoplastic, aplastic, whatever, you may have to change to a ABI, and that can be done intraoperatively as well. So the role of the MRI by and large is maximum to give you information about these two information, that is the fluid filled cochlea and the intact cochlear nerve. Besides, the other sequence of the MRI can give you information about any other pathology in the brain which can have an impact on the higher auditory functions. So that is another part. You can have a detailed information on the other sequences of the MRI. So our case is ready. Before we move on, anybody, any comment or any questions? Because this was simply how to look at CT scan and MRI from cochlear implant perspective, not getting other information for other surgeries or anything from the temporal bone. So Kapil, Samdani sir, or anybody, sir, please.
Satish, can I add something?
Yes, please,
That
sir.
when a request is made for the MRI, it should be written that preferably it should be 3 Tesla rather than 1.5 Tesla.
Yes, you can get a better information of the inner ear, interscalar partitions, better information of the initial changes into the cochlea from any other pathology. For example, let me give you, many a times we get post-meningitis patients, early post-meningitis patient, and an MRI is, phenomenal in picking up early fibrosis, early changes, which can turn into profound sensory hearing loss, which can turn into cochlear rehabilitation further. So those changes can be picked up by a 3 Tesla MRI with different sequences in a better way. Any slightest change in protein composition of the inner ear fluid should preempt you of the impending cochlear ossification in a post-meningitis situation. And the sequence we take into consideration for that is a 3D flare. In 3D flare, the cochlear fluid signal is dark, just opposite of the Fiesta sequence. In that situation, if you see any slightest change in protein concentration in the cochlea in post-meningitis situation, you can imagine the cochlear ossification is likely. That is very highly likelihood of cochlear ossification. And that is the time to take a call of implanting. If that is the implant is not possible for the patient affording so many things, you can at least stand the cochlea with a, a dummy implant to keep the lumen intact for the future. So the MRI sequences are very important. Timing of MRI is very important. What sequences can give you best information in the earliest, changes are most important, and that you can pick up in that scenario is by a 3D Fiesta. So your point is valid. A 3 Tesla MRI is more informative.